So we'll move on to the second layer in regard to the management of HCC, which is really when we come to the local regional treatments. And maybe we'll start with Riad to kind of like, please guide us through. There's too many, you guys like acronyms, like, TACE, TAE, TACE, Y90. Please, can you just kind of just go over the lexicon, if anything? So.
Sure. I think we're not unique in liking those acronyms, but I'll give it a try. So there's no doubt that what you're referring to here is sort of the therapies, the transarterial therapies, and they sort of start from the simple and elegant techniques of bland embolization that involve injection of particles to complete stasis to cause tumor necrosis. The gold standard by most guidelines is conventional Lipiodol chemoembolization with doxorubicin, or in some cases triple drug. That evolved into drug-eluting bead chemoembolization, the idea that you can better concentrate drug within tumor and minimize systemic toxicities. And then there's the radioactive particles called radioembolization, which is technically the same thing, but in that case you're just injecting radioactive particles. So we really sort of have a pretty big menu of types of treatment options, and I think it's clear from sort of where these treatments are practiced that certainly there is a center individualization and patient individualization, but all of these are clearly applied depending on the center that you're in. Absolutely.
And if I jumped on to Laura in regard to those local therapies, we hear about the concerns about what can happen liver toxicity-wise. So can you guide us through kind of, first in regard to TACE and TAE, and then talk about yttrium-90 in that regard?
So the key difference between those two intraarterial therapies is that TACE and TAE are a embolic therapy with the goal of inducing ischemia to lead to tumor necrosis. Whereas radioembolization, you actually need oxygen for the radiation to be most beneficial, and it is microembolic. So you maintain the patency of the hepatic artery, which allows you to treat patients as an outpatient, whereas patients who are receiving chemoembolization still traditionally are hospitalized to manage symptoms for a short period of time, such as abdominal pain, nausea, fever, etc. Both of those treatments, though, you are trying to kill a tumor that is living usually 90% of the time in a diseased liver. So there is always concern that you will actually cause necrosis of the uninvolved tumor tissue, potentially leading to further decompensation. Jaundice, encephalopathy. With recurrent treatments, you can start to see increased portal pressures, variceal bleeding, etc.
And can you tell us a little bit more about, the long-term effects, in other words, that can happen after several months in regard to yttrium-90?
So there can be, I think in my experience, I've seen this more long-term with patients who have METs as opposed to liver-directed therapy used for HCC. And there is a difference in the anatomy and the arterial blood flow. When patients have underlying cirrhosis, they start to rely more on the hepatic artery because of the portal hypertension. Whereas in patients who do not have underlying liver disease, they're maintaining most of their blood flow from the hepatic artery. So I've actually seen more long-term issues in people who have metastatic disease where they develop significant fibrosis, and that may be that you're treating the entire liver. It may be because of differences in the blood flow. It may be that they actually potentially live longer or don't get transplanted as opposed to patients with underlying HCC.
Sure. Richard, as a medical oncologist, of course, we are comfortable within the zone of systemic therapy. And we just heard it's very important. And what can we tell to our colleagues in regard to yttrium-90 as an advanced therapy that currently being practiced? And I think we'll ask Riad in a second about his experience, because he has probably one of the most important experiences with the therapy worldwide. But kind of, what's our obligation in regard to as medical oncologists to make sure that we introduce those therapies to our patients as well, and kind of assure them that they are definitely appropriate and safe?
Yeah, well, there's no doubt that local regional therapies play a role in the management of HCC. If we look at patients staged by the Barcelona criteria, this would be the Barcelona B group or the intermediate group. These patients typically have multinodular disease, Child-Pugh AB, and are well compensated and good performance status. I think going to that concept of the multimodality management it's important to recognize the limits of local regional therapy and to stay engaged in the management of our patients, because we're seeing now that we have effective systemic treatment. And in order to get a patient onto systemic treatment, we need to capture them before they become too ill. And that involves interacting with the interventional radiologist, the hepatologist, to recognize when a patient is no longer an appropriate candidate for local regional therapy, whether it be Y90 or conventional TACE, and being able to triage those patients to an appropriate systemic treatment now in front line and expanding that repertoire to agents effective in second line as well.